Sort of objective tests exist now that will actually show a brain injury?
I mean, there are SARA scans, SPECT scans, functional MRIs, but these are like really expensive studies. Usually insurances don't cover them. Many times, like personal injury attorneys recommend these type of images, but sometimes they don't even show up what we're trying to show. So something that has been around for dozens of years, but I just don't think it's caught on to like the industry as far as testing for brain injury is called a video nystagmogram. It's a VNG study. And it's exactly what we do and what we test as a vestibular therapist. We're testing the eye movements, we're testing the inner ear function. But this study is these goggles, and it's connected to objective norms on the computer as like what's normal for your eye to do with certain tasks, as well as like how well should your inner ear vestibular nerve function with certain stimulus. So a lot of the times people can have like a like a cerebral brain concussion and also have memory deficits and attentional issues and more central signs, as well as like certain visual, like your eye is controlled by 4 different cranial nerves, and those come directly from your brain. So if your eyes aren't tracking right, then there's only one place that can come from. And that's assuming like they didn't have these symptoms before or these issues before. So that is the only thing, is we don't have pre-head injury tests on every patient, but we have on the normal population. So we know what's normal for a 38-year-old female, for example. And then we can test like how the inner ear functions. And there's something called a labyrinthine concussion, where you can have a concussion to your inner ear organ that controls like your balance system and your dizziness. And a lot of the dizziness can come from that, or it can come from vertigo. It can come from the neck. It can come from the eyes not tracking. So it's really pretty complicated. But the VNG testing is something I've been trying to use a lot more for objective data on, especially patients that have been in car accidents, to help support the fact that they have these injuries, as well as some of the objective testing we do in the clinic. And then there's always the subjective report. But most of the time, it seems that neuropsychology testing seems to be like the gold standard of testing for certain brain injuries. But again, that's not extremely objective, and it's a really long test that a lot of patients can't tolerate a 6 to 8 hour brain test. So it's technology. There's some different eye virtual reality goggles that are coming out that you can run like a 5-minute screener on the eye tracking, and essentially this should be like on every sideline in every emergency room in the country. But it's just also cost and accessibility if you're in more rural areas to have those resources. But a lot of that technology shows the ocular tracking deficits very objectively. Like there's no argument as to, when you look at this picture, that the eyeballs don't look like they're tracking right. But it's just really cool technology, and I think it'll just get better as time progresses. But that's kind of where we're going. We say the eyes are the gateway to the brain, so a lot more research is being done in this area, and as far as like objective testing. So it's just something we've been doing for like a really long time from vestibular perspective, because that's how we test for patients with like Meniere's disease or like inner ear viruses or different things to figure out how well their inner ear is working. It just hasn't been used as much for like brain concussion. So
help me explain to the audience some of the things that may seem very simple to you or innate in the work that you do are confusing. So someone gets into an accident and the EMTs respond and they do a Glasgow Coma Scale, and people say, I got a 15 and I'm fine, but I'm not. Something's off. What does that test really do, and is it indicative of a brain injury?
So that test is testing for much more of a moderate to severe brain injury of like, are we in a coma? Like, are we alert and oriented? Are the eyes reacting? Like, so it's testing much more severe brain injury when someone is unconscious or in like a comatose state. Usually to classify more of a severe TBI, you have to have lost consciousness for more than 20 minutes and have like a positive brain bleed to get in that more severe category. And that's when people qualify more to go to rehab. Like Craig Hospital, I worked there in the past in like these hospitals that treat more severe TBIs. But it's the more mild to moderate TBIs where you don't have to lose consciousness. You don't even have to hit your head. And that you can still have these symptoms. So we use, it's called a Rivermead post-concussion questionnaire. So we use a questionnaire that goes through all the subjectives, at least to guide us in the right direction of like where this person's hurting. And what symptoms they might be having so that we can kind of dial in our treatment to giving them what they need to get better.
Isn't a Glasgow Coma Scale kind of silly in a way? And what I mean by that is it's a scale of 1 to 15, right?
Right.
1 being you're in a coma.
Correct.
And then 15 being you're perfectly fine. When you're trying to triage someone in an accident scene,
yeah,
if they're in a coma, you can't do the Glasgow Coma Scale anyway. Right? They're unconscious. You can't even use it. That's what I mean by it's silly. For the real severe cases, it doesn't even apply. For everyone else, it seems like it's a way to check boxes for the emergency response teams. And I hate to say that, but I've told many people that have come into my office complaining of brain injury that the Glasgow Coma Scale is not dispositive of whether you have a brain injury or not. It sounds like something like the Rivermead concussion questionnaire would be way more effective at determining that. Is that true?
Yeah, and you also kind of think about the setting. EMT, emergency room, they just want to know, are you going to die? So like in that situation, is that appropriate? Yes. You know what I mean? Like most likely they are trying to triage, like, is this patient need like life-saving measures? But when we get into like the outpatient setting, but even in the emergency room, I've been working with a lot of emergency room docs in the area, trying to get them concussion information and like, here's ongoing signs and symptoms, watch for these things. Because a lot of the times people are just, you have a concussion, have a nice day, here's a pile of paperwork you can't read because your eyes don't work well, and they just put it on their desk and try to figure out how to do life, and then all of a sudden life isn't going so well and I have all these symptoms. So it's definitely appropriate. The Rivermead's appropriate in the outpatient setting if it could be done more in the emergency room subjectively, but I just don't think they have the time enough to be able to care to like assess that in any more detail, because it's not going to change their treatment. They're going to say, okay, you're stable, you don't have a brain bleed, here's some information, you can be discharged home. But even in that case, the information of, oh, you don't hang out in a dark room until your headache goes away, like that's 20 years old research that now we know like that's not how you treat a concussion. Like maybe for the first day or two of having brain breaks and brain rest is appropriate, but you have to expose your brain and use your brain to heal it. And even that misinformation is still coming out of like at least the emergency rooms and primary cares in Colorado here. So trying to educate people like this is not what the research shows these days.
It sounds like the responsibility is almost on the patient or the person that was injured to really follow up and find out whether they in fact have some sort of brain injury, they have PCS, post-concussion syndrome, because you're right. And we're seeing the same paperwork out of the ERs here in Arizona. I can pull it up and show you it's the picture of the head, the diagram of the head. And it says, if you have these, then immediately consult with a doctor. And it's all very antiquated, very old literature and information. And so people are telling us weeks after an accident that something's off. They don't feel right, but no one's encouraging them to go get these various tests done and follow providers and tell them about these complaints. And I think it's because they're being told at the accident scene, they had 15 out of 15 on the Glasgow Coma. They go to the ER, you're right. There is no brain bleed. There is no objective finding that can be evidenced on an MRI. And so they're sent on their way, and then they are left kind of to their own to find out whether or not they actually have an injury. And that's a scary proposition for people because they don't know what to do. And now they're suffering in some way, and they don't find someone like you or others that are really interested in treating the brain. They could fall through the cracks and really live with this debilitating condition.
Yeah, and I would say, I mean, this is my clinical guess, is probably about 70% fall through the cracks, because a lot of people like, oh, I have this physical pain. People know my neck hurts, I have a whiplash, I need to go to the chiropractor, I go to the PT. Then they get that treatment, but it's like after 20 visits, 30 visits, 40 visits of PT or chiro, and I'm still dizzy, I can't see right, I'm not remembering things, and nobody, even in that setting, tells them that they need to go get worked up for a concussion. Like, that's a whole nother problem, is that like a lot of practitioners aren't seeing what's right in front of them and listening to patients' complaints. They're just treating like the physical injury. So many of our patients here have been to lots of other places before they come, and we just know that it's like the same kind of thing. Like, you got treated. Their med pay runs out. They have this huge lean to a PT or a chiro, and like, oh, now I have a concussion? What? So, I mean, I'm sure you see the same thing, and I don't, like, besides starting some kind of foundation of some sort to like try to educate people, I had this mission, like no concussion left behind, and I wanted to try to do something big with this exact problem. And I met with all these PTs actually around the world, and we had a Zoom meeting, and we kind of came to the conclusion that like the doctors don't really want to listen to the therapists. So we kind of like left to do things like this, and, you know, YouTube and online education and Google, and trying to get to the people directly, because it's really too much of a battle to try to educate like the people that need to be educated for people to get the help they need.
You're right. And I think because it's an invisible injury, you know, look, we can all agree that pool safety should be, you know, a real topic of concern in society, and we need to monitor, you know, our kids around water. And there's a lot of public service announcements about that, but we don't hear a lot of public service announcements about the brain and injuries and how your brain can be impacted from a variety of different things. And there isn't enough. I think there isn't enough chatter out there for people to engage in. And then there's this problem with the medical community, where your doctors aren't supporting it and aren't necessarily wanting to spend the time to rehabilitate people to heal the brain. And I think that's a challenge. And so because it's invisible, you don't see it, I guess we don't talk about it. And that's a really, really odd way to go about it, because as research has continued, and, you know, movies like that movie Concussion that came out a few years ago, that brings, I think, at least a little bit more knowledge into society, because then people are like, oh, that's the NFL thing, but it's not just NFL players, right? It's a lot of different people that are impacted. Mary, play a quick game with me. True or false? True or false? Just say true or false, and then explain why. You have to actually hit your head to have PCS.
False.
Why is that false?
Well, there was this old school theory that the coup counter to coup injury, where like the brain shakes in the skull and hits the front and hits the back, and you get bruising. But we know now, with like a lot of really cool research and technology, like those neurons are actually getting stretched or sheared, and it's that neurochemical connection that is not allowing the neurons to communicate with each other. So you don't actually have to hit your head. Even if you're rear-ended at 15 plus miles an hour, you still can be like jolted pretty bad, and your brain is just like jello floating in your skull. So it moves around a lot.
True or false? You have to actually lose consciousness to have PCS.
Definitely false. The loss of consciousness puts you into more of like the moderate to severe categories, but you definitely do not have to lose consciousness. Anytime you see stars or blurry vision after you hit your head, that's a concussion.
True or false? The little lowercase m that shows up behind or in front of a TBI, where it says MTBI, like indicating mild traumatic brain injury, means that you weren't really hurt.
Absolutely false. Most of my mild traumatic brain injury patients are worse than the severe traumatic brain injury, because the severe patients got help right away because they had positive imaging, positive Glasgow, loss of consciousness. So the attention was brought to them that we need to get therapy. Whereas like the mild TBI patients or the PCS patients, which is usually like more than 2 to 4 weeks after head injury, just are left to figure it out on their own unless somebody tells them where to go.
explain the lag that occurs in these mild traumatic brain injury patients where they don't get treatment right away. What impact does that lag have on people and their ability to recover?
Right. In the current literature, the faster you get therapy and rehab, like the quicker recovery you're going to make. So people start compensating really good. Like if your balance and your vestibular system's off and you're like touching the wall everywhere that you're walking because you can't walk a straight line. I usually tell my patients when we start doing like the balance testing, they say like, why are you sobriety testing? And I said, having a concussion is like being drunk without the fun part. And so you just compensate. Oh, like someone has a double vision. Oh, I just close one eye to read on my computer to do my work because I realize I can't see with both eyes open. So people just realize something's wrong and their body's not working right. They don't know what it is, but then they start compensating. And the quicker you get therapy to retrain that, then the less like it'll be harder. It'll be easier to retrain it properly rather than use like a lot of adaptive tools and strategies.
So there are a lot of symptoms that can follow a brain injury. Mm-hmm. I jotted down a few of the more common ones. Can you explain what sort of, I'm going to go through a list. And so just explain kind of what you see or what you've dealt with your patients. What kind of neurological changes can occur?
Headaches, definitely a lot of headaches. And headaches are tough because you can have like six different types of headaches. Are you there?
Yep.
Sorry, my daughter was trying to call at lunch break. And so, you know, the headaches, double vision, blurry vision, ringing in your ears, dizziness, memory changes, trouble like finding your words when you're talking. Well, there's a whole, well, she's going to just keep calling me.
I love it. Kids don't care.
Sorry. And so we go through this whole list and ask these symptoms, but a lot of the times even hormonal changes can occur. People can have like increased cortisol levels and like this huge nervous system response where you're like sweaty all the time and you're in that fight or flight mode. So that's like a huge sympathetic overdrive versus like our body should be able to rest and digest and find this like balance of being overdriven and not, but they've had a stress response. So then their nervous system's really screwed up, increased heart rate. Something called POTS, which is postural orthostatic tachycardia syndrome, is when you have like this uncontrollable change in heart rate as you change position. And that has to do with the brain dysregulating the heart rate. So that, like I said, it just really affects the whole system. So any of these symptoms can be something that's really hard to see, but you definitely can feel. So
what about emotional reactions that maybe aren't normal? Tell me a little bit more about that.
Yeah. Thank you. I forgot that. But yeah, a lot of people it's called being labile. They just cry more easily or for no reason, or they get very short fused and upset because that frontal lobe dysregulation. But their brain's just not, it's overwhelmed, and then it's just not regulating the emotions properly. Plus, like, oh, I can't work because I have this injury and I have this pain and I can't support my family. And there's like so much more that comes, that piece of the emotional, you know, element of like brain injury that also really drives like the anxiety. If you have like pre-existing anxiety issues, it makes the anxiety a lot worse. So there's a lot of emotional changes that can happen, unfortunately, too.
You have this really cool graph. I'm going to throw it up on the podcast. I know it's not in front of you right now, but it's the energy pie. And I thought that was the coolest thing. I hadn't seen that before. Explain the energy pie, because I think it's a really interesting way of explaining how our energy is used and how our brain functions.
Right. So with like a normal functioning brain, you have a good storage of reserve and you get enough sleep at night and you have like enough energy to physically function, emotionally function, and cognitively function. But when you have a head injury, you don't get as much sleep as night. You're having nightmares, you're having pain, you can't shut your brain off. And so you don't have as much of a reserve. Plus, your other systems are using more energy just to make themselves work correctly. Like, okay, I can't stand on one leg and balance because my balance is off just to get dressed. Mm-hmm. So I'm going to use extra energy to do that. Or I can't remember what I'm supposed to do when I go to the grocery store. So rather than writing it down or using strategies, I'm just using extra energy to do that. So then essentially we say like you kind of wipe out the brain battery. So we use this reference a lot with the patients to be able to understand like where they're at with their day, and like explaining to their family that my brain battery's dead, I need to go lie down, or I need to take a break. And that is when it is important to take brain breaks and to possibly take a nap if you need. But we also, try to get people sleeping at night, because that's when your brain neurons actually regenerate and heal, is when you're sleeping at night. So the brain battery is a really important thing to understand. And then once people understand that's happening, then they figure out how to like regulate that better.
I'm glad you brought up the family, because in this literature, you have this idea of a team approach, and you say list out who your neurologist is, who your family care doctor is, who your family members are, or support at work. Why is it important to have all those people on board working with you to try to heal from a brain injury?
Healing from a brain injury is like a full-time job, and some of these people are the breadwinner and the provider to their families, and that was a full-time job. So if everybody understands how much work this is going to be to get better, then everybody can work together to help the person have the support and the tools they need. Sometimes that means the other spouse needs to get a job and help support the family financially while mom and dad gets better. Or sometimes that means the kids need to pick up some slack and do some chores, because the stay-at-home mom with a really bad concussion can't do all the things she was doing to manage the home. So it's really important that like the family and the support system helps the person heal, and that the team members and everybody in the healthcare network works together. That's probably the hardest part, is having like an integrated care practice where everybody works together and communicates, which I feel lucky enough to have a part of. And we have monthly meetings and talk about our patients and what else they need to do to get better. But a lot of people kind of are getting a little here and a little there. And so it's hard to kind of balance all the therapy appointments and everything. So
if you had your, how do I want to ask this question? If you lived in a perfect world, and you could spend a certain percentage of your time hands-on patients, a certain percentage of your time researching and learning more about the advances in brain injury, and then a certain percentage of your time educating those about brain injuries, how would you allocate those three things? If you had to equal 100%, I'm putting you on the spot.
That's really hard, because I try to do all those things in just the same way that I have a full-time job, and I do all the research on the side, and then I go around to the emergency rooms and the primary cares and try to educate them. So, I mean, probably education needs to be even more so, because then more people would get help. And so what I'm hoping is even more knowledge of concussion, and more clinics are starting to get into like, even though maybe a therapist went to a weekend course on concussions and now they treat concussions, like at least they're probably going to get something over nothing, and identifying that it's a problem and getting some kind of direction and help, at least from a vestibular perspective. But I would say like a third of each of those, like to really do everything that needs to be done to help. But I mean, so much more education needs to be out there for people to, and the research is there. That's what's really terrible, is like, unless you're actually invested in looking at the literature, primary care, emergency room, chiro, PT, they're not looking at the specific literature. They might be looking at other medication literature or, chiropractic adjustment literature. They're not looking at that. So what I do is I actually take literature to doctors' offices and say, like, this is like the standard of care for concussion management.
Are they receptive? Are you finding that people are interested in receiving that information?
If they're willing to listen.
It's like with kids, right? If they're willing to listen, you can impart some great wisdom.
Yeah, exactly. And actually, speaking of kids' concussions, unfortunately, I've had to deal with this with my 9-year-old daughter, who's had 5 concussions. And these weren't just like, oh, my mom's a concussion doctor, I bumped my head. This was like, she couldn't walk for 2 hours after she fell out of the hammock and hit her head. And like pretty legitimate concussions. Yes, no loss of consciousness, but severely affected her ability to learn to read, because it happened at the age when she was learning to read in 2nd grade. And her eyes not tracking right, and her ability to pay attention. She would say all the kids in the class are hammering on her head. And I was like, what is she talking about? And then I realized she's overstimulated, she's getting sensory overstimulated. So at least having the knowledge I had has been able to get her like the proper tutoring and occupational therapy and vision therapy and the things she's needed to like be able to not completely fail out of school. But I just wonder, I mean, how many kids hit their head? All of them. So she actually wrote this book. It's like My Invisible Injury, a story of kid concussions.
Oh, wow.
So if anybody is a publisher, I have just published it on Shutterfly myself, but we are trying to find someone to help like get this out because there's not a kid's concussion book written by a kid. So we're trying to share her invisible injury story to like more kids. So people, because kids are really, really hard to see these injuries in. That's
so great that she did that. I would think that the children's hospitals all around the country would want copies of that in their hospitals just because kids relate to kids. And if it's written by another kid, you're more likely to listen to it than there's another doctor or another parent telling me what's wrong with me.
Yeah.
That's so really cool.
We're working on someone getting us a publisher and trying to get more copies out there, getting it on Amazon, just because it's really actually very challenging to publish a book. I didn't know.
I would imagine. I haven't tried it myself, but I would imagine it's not easy. So we talked a bit about the auditory issues that come up with brain injuries, and we've personally dealt with some tinnitus. Am I saying that right? Tinnitus? Is that how you say it?
Yeah, or tinnitus. I mean, it just depends on who
tinnitus cases. Yeah. Can you tell me as a clinician more about tinnitus? And because we're educating ourselves as we have dealt with that more recently. How does that interplay with brain injuries?
So you're, hold on. Here's an ear.
Okay.
Okay, so your inner ear organ and the sound nerve and the vestibular nerve are like right next to each other. So when you have a concussion, you can have like a concussion to this whole system. And the tinnitus is like a confusion between what the brain hears and what you actually hear. Sometimes you can have traumatic hearing loss from head trauma, and that's where getting an audiogram done to check the hearing is important objectively. Because if somebody has objective hearing loss from a trauma, then you know they might need hearing aids or they might need something. There's like hearing aids that block the tinnitus, and there's an app on the phone that kind of negate the tinnitus. I usually have people do a tinnitus alleviator app where they listen to different sounds for 15 minutes every night to kind of like retrain what the brain hears. But those patients with the tinnitus and the severe dizziness and balance issues, that's where most likely that labyrinthine concussion has occurred, and that's where the VNG and the vestibular testing as well as the hearing testing can be really objective to figure out like what is happening in this little tiny organ that's like the size of my pinky. But there, you know, it's really hard because it's just sometimes time and healing, but the sound therapy can help. I would say 80% of the time, if I have the patients do sound therapy, it helps relieve it, or it helps like dissipate it. And then sometimes people just figure out how to compensate, and they're like, oh, I run a fan or I play music, and or it's a sign of the brain energy being zapped out, the brain battery, and that like that's a symptom that they're having, that they're overstimulated, their ringing gets worse in their ears. So it's
a terrible sound. They have those clips that you can listen to online. I couldn't imagine that being in the background all day long every day. I would say like anybody with like severe tinnitus should absolutely see ENT or audiologist. Yeah. All right, Mary, before I let you go, I like to do this with all my guests. I call it Fast Five with Mary Finck. These are not related to brain injuries. These are just questions that are random. Good luck answering them. I'll just go ahead and go. First question. Fastest Murph you've ever done?
Oh gosh, that's probably like 53 minutes or something. But I did do a Murph when I was like 37 weeks pregnant, very modified, but I did do a Murph. So that's impressive.
That's really impressive. What food is your guilty pleasure?
Probably chocolate or something along those lines.
But if you say dark chocolate, everyone thinks you're healthy. They're like, oh, you just have dark chocolate.
No, any kind of chocolate, anything with some sugar.
Okay. Can you name all 9 planets? Your daughter's going to be listening to this. Can you name all 9? I'll be honest, Mary, I had to Google all 9. I got like 7.
I mean, so we have the solar system in our house because of homeschooling during COVID, and I have no idea. Jupiter, Mars, Saturn, Earth, Venus, Uranus. Oh gosh, that was 6. So you might have got me. Oh gosh, no, I can't.
Well, one's now like a dwarf star. Does that ring a bell? Because they kind of declassified it from when we were kids.
Oh.
Also a character.
Venus?
Nope, you already got that one. Already a character with Disney. He's a dog. Pluto, and then Neptune. Pluto, Neptune.
Oh, darn it.
Everyone forgets Neptune. All right. 4th question. If you were a cheese, would you be Swiss cheese or cheddar cheese?
Oh, I don't eat cheese, so I guess I would be cheddar, but that was better when I ate cheese.
Yeah. Last question. Would you rather wear a monocle or an ascot? Do you know what those 2 things are?
No.
The monocle is the eyepiece, the old, like the single.
Oh, okay.
It was attached to the shirt. It would be the eyepiece. The ascot is like the real fancy, fluffy, like thing that kind of looks like it goes over your tie. You wear the suit. Ascot or monocle?
Maybe the monocle. Might be a little more functional. I don't know.
You can imagine putting that on with your patients. You're like, let me put this on really quick. Have it attached to your box.
Yeah.
Mary,
like a hat.
Yeah, exactly. Thank you so much for joining the Legal Beagle podcast. Sorry about the technical difficulties, but you did a great job adapting.
Thank you. Yes, that's what we do. It's all about adaptation.
It is. We will do our best to try to get this message out, and hopefully at some point there'll be more conversations about brain injuries, and it'll be commonplace as opposed to things that are happening on the fringes.
Yeah, I hope so. Thank you for having me.
You got it.